This is Donna Kinchlow, and this is session 3 of Excellent Questions, which were given to me by wonderful new nursing students. Grief, loss, and spirituality has been important to this generation of nurses, and they submitted 64 questions, and this is the next session. And I'm so happy that you want to be competent about grief and loss and spiritual care. Why is it we do not receive as much training on death and dying? Well, today you do receive end-of-life care. It's taught to nursing students and also medical students. The importance of advanced directives, understanding hospice and palliative care is very important. We have resources available to patients and families that we didn't used to have years back. When you think about the amount of curriculum that you have got to absorb and the number of clinical hours that you have to have, training in death and dying may seem to be a little bit anemic, but nurse educators can provide electives, and there are several options to help equip you with this valuable information. To answer this question, why don't we receive training on death and dying in a more general thought? American society is often labeled as a death-denying culture. The reality that death greets all of us seems to be a myth. It's a topic that you usually don't bring up at the breakfast table. Patients and families and physicians may hold to the belief that death is an enemy. Some physicians were taught to save lives, and their education may have been a little bit devoid of communication skills and understanding how to cope with patients' death and the family's grief. People don't think about it until something happens to someone that you love, and then it will derail your life. When we work in healthcare, the goal is to save life and help someone obtain and maintain the best quality of life possible. We do have advanced directives, and people can give you their wishes, what they want done. In the event of death, they can pre-plan. People who are terminal, we have palliative care, we have hospice. For anyone who wants to learn more about death and dying, there's always certification programs and continuing education series. But let me tell you a true story about my dear husband's mom and dad, Mom and Pops. Mom and Pops had wonderful friends, Lila and Byron. They were their best friends. And Lila and Byron were hit by a train. Byron died immediately, and Lila laid in the ICU, got fluid overloaded. Mom and Pops visited them religiously, Lila for sure. And it wasn't until that happened that Mom and Pops, and they were probably in their 80s at the time, actually had a conversation about death and planning. And they went ahead and they got with a funeral home. They pre-planned their funeral. They had wills made. Now, granted, they're in their 80s. Can you imagine? They never had that conversation until their best friends ended up being struck by a train and they both died. And so sometimes, as we say, we may not have a whole lot of training on death and dying, and a lot of people want to avoid it. You know, we get busy. We never think about loss. We never think about things happening that are out of the ordinary. But sometimes when that happens, and just like those of you who submitted questions, the greatest thing is now you're able to say, oh, I know this is real. And you want to know how to do this well because it is another chapter in our lives. So granted, there are things available where you can learn more about death and dying, palliative care and hospice, or any certification or elective on loss is a good thing. How do you provide the best spiritual care to a patient if their beliefs differ greatly from yours? Well, this question brings up spiritual assessment. First, I would say to you, how do you know the patient's beliefs are different? And my thoughts are sometime during the patient-nurse encounter, faith traditions may have come up. So here is an example of how you provide spiritual care to a person who has different faith beliefs. I had a precious patient who had to have a GI procedure, and it would extend her hospital stay, and she wasn't really excited about that. And she had a niece who loved her dearly and had keys to her house and kept calling, wanting to do something for her. And the patient just kept telling her, I'm fine, you don't need to do anything. But in conversation, I found out that this woman loved to read daily her spiritual sacred text. So I encouraged her. You know, Bessie, your niece really wants to do something for you. She's constantly asking, what can I do? Let me do something. Let me bring you something. When you have someone in your life that wants to help, you need to let them. And I told her, have her bring your sacred text. Well, my patient listened. And later in the afternoon, when I walked by her room, she was so relaxed. She was sitting in a recliner and she was reading her sacred text. And there was just a piece about her that hadn't been there for a couple days. That is spiritual care. Totally different sacred text than what I have, but I was able to help her and encourage her to do what met her spiritual needs. And you can do the same. If someone talks or asks you something related to their beliefs that are different from your own, how do you properly respond and care for them without interfering with your own beliefs? I will start this with telling you that what do we know about holistic care? You are physical and you are emotional and mental and you are spiritual. Your faith and spirituality are all part of you. And respect belongs to you as well as to the patients and the families. You know what you believe, and patients do not need to shake your faith. Now, you will meet some. I had a little man who had blue knees. Now, as you grow in your nursing education, you're going to understand that a bluish tint shows you that there's a lack of perfusion to the body, whether it's the heart that's in bad shape or what the problem is. In my career, mottled blue knees, not a good sign. It's usually you're going somewhere soon. He put every argument about my faith he possibly could. When he found out that I was a Christian, he said to me, "You're a nurse. You know how babies are made." He was discounting my belief in the virgin birth of Jesus Christ. And so my response to him, a little bit of a broken record. Yeah, I know where babies come from, but I believe my God is big enough to send his son to earth and with his Holy Spirit create a baby. And then he would say, "You seem to be a very intelligent nurse. So I'm having a hard time understanding how you can believe such fairy tales." So what is he telling me? He knows enough about the Christian faith that he discounts it. And so he hit me again. "You've seen dead people. You know people don't rise from the dead." Discounting my belief in the resurrection of Jesus Christ on Easter. And my broken record response to this dear sweet guy was, "I believe my God is big enough to raise his son. I believe the Easter story. And at that point, his daughter rushed in and she actually heard the tail end of this discussion. Whoa, she says to me, "Are you trying to talk my dad into believing Jesus?" For a moment, I thought, oh boy, this might not be good. And I said, "Would that be okay?" Pouncing on the bed with her hand on her daddy's chest, she nearly sobbed. "Daddy, you have to trust in Jesus. Daddy, you need to believe in Jesus." And I took a breath of relief and walked out of the room and left those two alone as they tried to sort out their faith differences. The point of my story: you may find some who try to discount whatever faith tradition you believe. However, our job is to educate, encourage, and equip these dear ones with compassion and kindness. There's no need to get upset. There's no need to be angered at what's going on, because once you know what you believe, you hold on to your belief just as they may as well. Beliefs may differ, but your nursing care stays the same. You are professional. You are compassionate. If their interaction with you causes you to consider other faith tradition, well, that's your personal choice. When you are part of a healthcare organization, do discover the spiritual care resources that are available for your patients. You might find the chaplains, the priest, the rabbi, whoever is on the pastoral care team. If your patient is Christian and you consider yourself to be non-religious, perhaps there's a coworker who believes the same as your patient and would be willing to talk with your patient if it's uncomfortable for you. Always be honest. The patient is going to be so appreciative if you provide someone to meet their needs. Your response is always one of honesty, transparency, and action. You are going to be the best nurse that you can be for that person, because remember, holistic care, you're always going to be taking care of the physical, emotional needs. You're going to be educating them. You're going to be that nurse that they want taking care of them. And this is not going to drive a wedge between you. Here was a wonderful question. Now, this is an in-depth question. What are the different types of grief? I know there's different stages, but what about the different types? Well, if you would Google and search different types of grief, you're going to find in all kinds of wonderful websites that are extremely correct, anywhere from 7 to 16 types of grief listed. I'm not going to go over all of them, but I'll give you some, and I do believe I will make you a handout with this later on so that you can pull this down if you're interested in a more in-depth understanding. The Cleveland Clinic website addressed 6 different types. You can have what is called anticipatory grief. If I receive a diagnosis of cancer, I can anticipate loss is coming. And you anticipate the loss before it's a reality. So processing grief ahead of its time is helpful. You can anticipate it's coming. Abbreviated grief. Some people go through the grief process at warp speed. This may indicate mutual grieving has already happened. The one dying and the one left may have actually been working on grief together. And then there is delayed grief. You're so busy planning the funeral, planning the celebration of life, you just didn't give yourself any time whatsoever to really understand what has taken place, and days or weeks or months later, delayed grief can smack you. Those obstacles, the business of planning the funeral, the burial, contacting people, collecting all the necessary financial and business issues can steal away the time it takes to absorb the loss. But it will happen. Inhibited grief, that's where repression of your emotions can manifest in physical symptoms. You might get a little bit of a panic, anxiety, insomnia, GI issue, and that is repression of your emotions. Cumulative. One of you asked a question in the future about multiple losses. Cumulative multiple losses have accumulated. The grief is complex and overwhelming. Oftentimes, it seems that men don't like to deal with loss and grief. And if you haven't dealt with the grief and they are stacking up, so to speak, it can be quite overwhelming. You could have a loss of a child, the loss of a job, loss of a marriage. Those are all examples of cumulative grief. Collective. Usually grief is personal, but with the losses of 9/11, the losses of COVID-19, we all as Americans shared the losses and the struggles. And what did we think about? What's next? I will get you a handout to download. And there's also going to be a question about complicated grief, and that is when a person is stuck and definitely needs professional help. How do you help a patient that is experiencing physical signs of grief? Well, I worked many years in heart. I loved heart. I did open heart surgery. I didn't do open heart surgery, but I cared for patients who had gone through open heart surgery. I was also the heart failure coordinator. So one of the things you have to be very, very cognizant of is that people who are grief-stricken are subject to a broken heart syndrome, and it is called Takotsubo cardiomyopathy. So you want to assess the patient for their heart issues, signs and symptoms of this cardiomyopathy. And if you're a wordsmith, cardio is heart, myo is muscle, so it's an abnormality of the heart muscle. And when they present, they have chest pain and shortness of breath, and they feel like they're having a heart attack. And they believe that it's the surge of adrenaline that stuns that left ventricle and weakens that heart, and it's transient. The patient will recover. They may do a catheterization, a cardiac catheterization, where they check to see are the arteries patent, and they will show that yes, indeed, their coronaries are not blocked. The echo may show a decrease in pump function or ejection fraction. So stress reduction, medications, and time will heal this heart. And they will get a repeat echo that will show healing. And the medicines that they need to take for a while to help strengthen the heart may just be for a short season until the heart is back to its normal shape and size. You could also experience the anxiety, decreased appetite, and insomnia is a biggie as well. And those are more generalized symptoms of grief. Knowing to eat healthy, exercise, limit your caffeine intake is also very helpful when you're dealing with grief. Make sure that you eat and you eat well and that you drink your water. Which stage of grief can be the hardest to get your patient through? Well, one of the things that we know is that every patient will go through the stages of grief on their own timeline. You'll spend so much time in what? Denial or anger or acceptance. Is it ever really coming? Well, you might jump back and forth between those stages. We do know what stage is hardest, and depending on where you practice will determine which stage of grief you see. In the acute care environment, diagnostics can lead to the findings of terminal cancer or life-threatening illness. If the patient is going to be told by the physician, I would say to you, please go in with the doctor and hear what he tells the patient. When you deliver such news, the patient and the family can be so shocked that they aren't going to remember what they said. So you need to be there so you can reiterate and support them. Sometimes you will be the one delivering news to the patient. Oftentimes, new nurses and nursing students think, am I allowed to tell people the results of their tests? Well, absolutely you are. I had a wonderful patient, her name was Shirley, and Shirley asked me, Donna, can you tell me the results of my test? And I said, sure, Shirley, I can tell you anything I know. Remember, you are a patient advocate. You are allowed to deliver whatever news is there. I said, Shirley, it looks like cancer. Have you got cancer in your family? And she was very calm about it. And she said, Donna, I am not surprised. I smoked for years and I am really not surprised. But the thing I worry most about is my husband, Georgie. He's got Alzheimer's or Parkinson's and we have no children. And so her greatest concern and spiritual issue was what was going to happen to Georgie. And that's really quite a story. But I want you to know, for Shirley, knowing what was going to happen did not bother her at all. She wasn't surprised. She knew her lifestyle and she knew her family history. And we talked about our family history. My father had colon cancer and died, and my son's dad had prostate cancer and died. And so you can talk about cancer because you know what? Cancer is around all of us. There's always someone that you know. And so that really helps. If you work in the emergency department, this again is going to be a place where people will be experiencing traumatic grief and perhaps multiple losses. So if you're there and you're in that phase, that might be the hardest stage you witness and you're a part of. So when you say, what's the hardest part to get your patient through? It may just be an introductory where you are supportive, kind, caring. You don't have to say a whole lot. You just have to be there loving and helping. Is there someone I can call? What can I do for you? How can I help you most? Being available at certain times, because that might be the hardest piece that you see. Now, if you work on an oncology unit, you're going to see patients at different times and through the different stages, a whole different ball game. You're going to know what's the hardest part for them, and they're probably going to tell you. Just like Shirley, who would have dreamt the hardest part for her was, I don't know what's going to happen to my husband, who's demented, because I know I'm not going to be here. She almost jumped into acceptance in a very amazing way. Okay, it's also documented when you look at this. When is the hardest time? For some people, it's that second year after the loved one's death. It can be the worst. Now, why would you think that? Well, that would be the time, if my husband died, I wouldn't want to make a whole lot of decisions during that first year. But that would be a time when I would think, oh my, am I going to sell his truck? The house is maybe more than I can take care of. I'm going to have to put the house up on the market. Do I need a smaller place? Do I need an apartment? What now? And sometimes all those decisions seem to be hurtful. And some people will even say, I've got a plan to move. I need to be closer to my children, my grandchildren, and I want to move. And when you know anything about a stress chart, any of these things are high on the stress chart. So which stage is going to be the hardest to get the patient through? Whichever stage you are going to be there, you are going to be a great help. And you are going to help them no matter what stage they are in. And they will tell you, if you ever ask anyone, what was the hardest stage for you? And if you have family, ask them. See what they say. How concerned should you be if someone loses multiple loved ones at one time? Okay, this is huge. The loss of multiple family members during a traumatic accident is something of tremendously great concern. So you are right on target. Survivor guilt. I'm sure you've heard of it. It can contribute to this loss scenario. And for this discussion, let's consider some tragic events that we're all familiar with. After 9/11, I had worked in IV therapy, and I wanted to attend a conference on critical incidents debriefing and stress management. So I attended this conference, and it was led by a woman who had her degree, and the insurance companies had found that during traumatic events, if you got people together and they were able to have a debriefing and talk about what happened, that it would be a much better scenario for all of them. They would have a better healing. And that's where, when you're talking about grief, once the patients and families are talking, you listen and you let them talk, because you're going to be someone they trust. So this woman counseled a group of survivors. Now, she explained the process of critical incidents debriefing. Everybody sat in a circle. They were given specific instructions. They need to keep the promise of confidentiality, non-judgmental attitudes, gave everybody the freedom to share. Everyone was expected to share. It didn't matter if your boss was there. It didn't matter who you were with. It was all about being able to be open. Job titles were never mentioned. The first round, state your name, your first name, the name of the building that you worked in, and tell what happened that day. Now, as she talked about this, she told us, you do understand, these people shared a common bond. They didn't go to work that day. That's why they weren't in the towers. And it was an amazing thing. The common thread of GI Blues came front and center. The first woman told her name and said, well, I'm embarrassed to tell you why I didn't go to work that day, but that morning I woke up and I had the worst case of diarrhea I've ever had in my life. And I'm embarrassed to tell you that. And on they went. And one of the men said, my wife went to work, but my little girl, she had the GI Blues and couldn't go to school, so I had to stay home. So they had survivor guilt, but it all turned out that illness kept them home. And you really think about that. When do you not go to work? Well, you go to work with bronchitis when you're on antibiotics, and you go to work with all these different things, but you don't go to work when you got GI Blues. And that was a commonality. And yes, they lost multiple people. Survivors and those who have lost several family in such a short amount of time need counseling. And as healthcare providers, we often neglect that in our own lives. I guess we think we're superhumans. I know I did. My daddy and my granddaddy died within a month of each other back in 1986. And I never sought out any help. What happens if a person never stops grieving, and if spirituality does not help? So grief is our natural response to loss. It's that individual process. Usually within a year, your symptoms are going to lessen. They say that for an adult, and they say about 6 months for an adolescent or a child. Professional treatment isn't necessary for the normal grief process, which allows you to adapt and accept the fact that the person is gone. About 7% of people will experience what is determined to be a prolonged grief disorder or complicated grief. A preoccupation of the one who died and the inability to accept the loss manifests itself with intense, painful emotions. And what can trigger those things? Traumatic events. An unexpected death of a spouse, child, murder, manslaughter, or abductions, where a child is gone and you have no closure. You don't know if they're dead or alive, and that grief is amazing. All those things can trigger complicated grief. And these people suffer. They avoid reminders of the one dead and have this intense pain and difficulty engaging in activities. My husband has a friend who pretty much became a recluse. His wife died, and he used to go out and eat with these men, and he will not go. Now, he'll talk on the phone, but he's pulled back. He's like a hermit. And another gentleman who used to live down our street, we invited him to a party, and he called and he said, I can't come. I've got other plans, but I haven't been down that street since my wife died, and I don't think I can drive down that street. It's been over a year, but he was married to that dear one for 50 years, and he loved her dearly. And he sold everything, and he moved after about a year. And he's totally in a different space. Don't know if he'll ever come visit us or not, but hopefully he's not dealing with this every day, because he is doing vacations. He is meeting with his family. He still has social connections, and said to my husband, let's do breakfast. So, is he healing? Yes. So if they have difficulty engaging in normal activities that they used to do, and they have an emotional numbness, and they lack any positive thought or positive mood, every aspect of their life will be affected if they don't get treated. Relationships, work relationships, even going to work, educational aspirations, and any social activity is going to be affected. They're going to suffer. And even religious and spiritual or cultural norms lose the effectiveness that they used to have. So when someone gets stuck in their grieving process, it's an important thing to let them know what's available to help them. There are tremendous grief support groups in different churches and in different organizations, and there's a wonderful group of online, or even YouTubes, to help people. You have to find out what method they're going to want to jump into if they will allow you to let them know that, this is what I'm seeing. These are the signs and symptoms. Or you might be someone like me that, I had a man who I thought had amyloidosis of his heart, and I actually printed off the patient education and highlighted all the symptoms that this dear one had, and brought it to him and said, I want you to read these symptoms to me and tell me what you think. And sure enough, and it was a wonderful way for him to see it in black and white, not just me telling him, because that's what I thought he had, and then we told the docs, and it all worked out very, very well. It was a miracle story. You can do the same, depending on the patient or your family member or your friend. Sometimes just getting them that black and white copy, make sure it's legit, make sure that it's researched and grounded in evidence, but also make sure that they can understand it. That'd be helpful too. So what would you say are the best techniques for the nurse to control emotions when facing someone who's experiencing one of the stages of grief? There are two questions, very similar, so let's read both of them. How do you keep your own emotions under control when dealing with patients and family members who are going through grief right in front of you? So when you are right in front of me, I'm going to tell you a story from my book, I Never Walk the Halls Alone. I worked on the IV team, and one night I went from one room to another room to another room, and I received stories about death of children. The first man just totally broke. His son had drowned his grandson. Oh my goodness. And then 2 more told me heartbreaking stories about shaken baby syndrome. If you're not sure what that is, shaken baby syndrome is a soft spot for me. Child abuse, it just breaks my heart. Adult abuse, yeah, elderly abuse, that does too. But when a person grabs a hold of an infant or a toddler and violently shakes them in anger, it causes that whiplash. That little brain of theirs slaps against their skull. And what does that do to the brain cells? And what does that do to that child? It causes severe brain damage. It can cause traumatic brain injury or death. And in my night, that night, all the stories ended in the child's death. I listened. I gave them what comfort I could give. I looked at those beautiful pictures. I found an empty room and I cried my eyes out. And I prayed hard. Wiped my face off and went through the rest of the night. When you are with someone who is grieving, your presence and kindness may be all that they need. You are going to learn so much by what they say. If they are talking, let them tell you their story. You are a nurse. You are one of the most trusted professionals that there is. And a lot of people are going to share their heartaches with you because they trust you. And they know that you care. We come with that. If your tears fall, let them fall. They will know that you care for them deeply and that you're sharing in that sadness. And you have nothing to be ashamed of. I just recently read a story. It was so cute. A woman delivered her baby and her baby died. And she asked the nurse afterwards, "Where is my doctor?" And the nurse whispered into her ears, "He's crying in the other room." And that knowledge gave that mother so much comfort. And you'll do the same. Don't you know? Gets you, doesn't it? Gets me. Remember, during moments of intense grief, words may not be necessary. They may even tell you and help you with their words. Your presence, a glass of water, a box of tissues may be appropriate. And yes, I have even used humor. I had a woman whose family was all around. All her adult kids, daughters and sons, they were so dear. And they had just found out that mom needed open heart surgery. And I could tell they were holding back their grief. And I had talked with a dear sweet patient and knew that she just recently lost her husband. So these kids had lost their dad, their father-in-law. I went to the bar. I got a gob of Kleenex boxes. I came into the room because I'd established relationship with all of them. And I simply said, "Hate to break it to you guys, we don't give medals for holding back tears, so here, let her rip." And I'm throwing tissue boxes at these kids. And they all started crying and laughing and crying and laughing. And yeah, you can use humor. And I will tell you, there are times that the patient will see you and do something crazy. I had a patient, I went to do his IVs. He was a cancer patient. He knew he was getting chemotherapy, and my pager is going off and going off and going off. And he looked at me and he said, "Donna, it looks like you're having a terrible day." Nah, it's just a lot to do. He goes, "Well, let me tell you what I do when I think it's a terrible day." And you know what that man did? He sang, "Smile. Though your heart is breaking, smile, even though it's aching." Ah, beautiful. So sometimes you learn more from them than they ever do you. And as far as emotions, I haven't been able to learn how to stick them under the rug. You come with them. You come with them. You know, I had a woman once, bless her heart, she was precious, trying to hold back the tears. I thought I could handle this better. It's okay to cry. And sometimes you're not the only one trying to control your emotions. Sometimes they are. They are. And by giving them permission, you're doing spiritual care. You're allowed to cry, guys. You're allowed to cry. How does a nurse cope with the feelings of death they experience, and does it get overwhelming, and what type of coping mechanism can you use? Well, one of the greatest gifts of becoming a nurse is learning how precious and how fragile life can be. We are very blessed people. We know a secret. First, I believe you need to do a self-assessment and decide, how do you feel about death? What do you think happens when you die? You know, you're going to have some patients that just come out and ask you, have you told anyone what you want? My husband knows the songs I want at my funeral. I'm even thinking of writing the sermon tips for the pastor. Nurses learn death is part of life. And it is a great privilege to help people through that last chapter, because guess what? You're going to be more comfortable with this than they are, and than their families are. Because yes, you're going to learn as time goes on. But you see, you'll see it all. You're going to see families with great faith singing songs and laughing and hoping and knowing that heaven is for real. Don't know if you've ever seen that movie. It's really cute. You should watch it. You will see people who are angry and hateful up to the very end. You're going to see some amazing family dynamics. And I promise you, your life will be richer. For you're going to know about this part of life that people deny actually happens. No one gets out of this world without this chapter in their life book. And you'll have the ability to make it a pleasant departure for those who are in your care. So my coping is my Christian faith, and I believe in heaven. And if you work in the Midwest, about 80% of those you care for will believe in Jesus and heaven as well. You're going to be okay, because when people are dying, you and your staff that you work with do this together. You and the chaplain and you and the physician, you all do this together. It's not like you're out there one man on an island. Nah. If you find the best unit to work, or maybe you're doing a resource and you're loved by everybody in the house, you're going to know that when death comes, people usually aren't alone. They're not alone. And you're going to start having your own little library of the things that you learn from grief and from loss. Yeah, it's not going to be as hard as you think. It's actually going to become a blessing for you. It always has for me. So our third session, we talked about how you care for people with different faith traditions. We've talked about the types of grief, the multiple losses, and our coping skills. You might even want to do some journaling, guys. It'd be a lot of fun for you. So I thank you so much, and I will get going on the other three sessions. I have 4, 5, and 6 yet to go. It's a joy, and I thank you so much for these wonderful, excellent questions. I'm hoping that I'm helping you realize you are very important, and I am so thankful that you've chosen nursing. Have a good day.